The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for November 20. This is Deanna Mitchell again with Leading Age Michigan, and we've seen another very busy week as we head up toward the holiday season. Caseload does continue to rise in many areas of the United States and definitely here in Michigan. And of course, there's always a lot going on at MDHHS and LARA. Before we get started this morning, we'd like to make an announcement about next week's schedule. Our next webinar is set for Wednesday, November 25th at 10 a.m. We will be holding that webinar, but we will not be holding a webinar on Friday, November 27th. However, we do want to remind everyone that we will continue to send out alerts through the listserv if something arises. And we also continue to encourage you to send questions and issues to the Safe and Calm email address or directly to either Dalton or myself. So for today, we're going to start with a very brief update from Dalton, our Director for Public Policy, along with a short review of some upcoming target dates. We're going to follow that with a quick look at some recently published Medicare COVID claims data, and then move on to new guidance. We actually have very few new updates for today, but because there continue to be so many questions about COVID relief facilities, we're going to do a review of that again, along with discussion of some of the commonly asked questions. So primarily today's session will be for skilled nursing facilities, but other provider types might be interested in care and recovery centers as well. We're going to talk about those a little bit. We're going to ask members to hold their questions about COVID relief facilities until the end of the session. We'll give you some time at that point if you have questions, because we believe we're going to answer many of your questions as we move forward. Definitely not all of them, but some of the questions will be answered in that discussion time. So at this point, we're going to turn the presentation over to Dalton.
Good morning, everyone, and I hope everyone's doing well. We have some brief advocacy updates, and really it's just an update to the calendar to let you know what to expect in a couple of weeks from the state legislature. There will be no legislative session days until lame duck kind of gets into full swing in December here. Right now, everyone is kind of throwing around the term a lame duck. This is to reference the fact that they don't expect any major pieces of legislation to be going through, but we'll be obviously involved in the process as that occurs. One of the big talking points, though, is that there will be a December supplemental budget that will be passed, but this has nothing to do with increasing or decreasing funds. This will just be a closing of the books or closing of all business items for the fiscal year for the state. And this is largely due to the fact that there is very little money for any additional projects at the state level right now. A lot of it has been spent to combat COVID, and we're kind of waiting on the federal government to pass another CARES Act type package or another COVID relief package. Along that vein, if you were listening to the governor's call yesterday at 3:15, you'll note that the governor did call on the leaders of the federal legislature to pass another coronavirus relief package, and she was joined with other legislative leaders from the state on that call to them via a letter. They are hoping something will be passed by the end of the year, but nationally there hasn't been a lot of willpower to do so. This is the important date slide. As I'm sure many of you were expecting, the CRC and CR application deadline has been added to this slide. That is December 1st. Also, to note, on December 1st, it is also the deadline for submitting in-person visitation aid CMP applications. This is for those tents or kind of, what's the word, hand sanitizer dispensers, or those kind of projects, not actual PPE. If you haven't submitted any kind of application for that, you have until the 1st. This was an extension from the original end date of that program.
Okay, thank you, Dalton. We've not updated our routine caseload graphs for today. We all know that the caseload is continuing to rise across the state. But we did take a moment to look at the Michigan numbers in comparison to other states. Caseload is also, of course, rising pretty much across the country. And since we had not looked at this for a while, we thought it might be a good time to take a moment and do that. Whenever we look at this kind of information, we also have to note that the raw caseload and death numbers are really not very meaningful if you're comparing one state against another. So just because we are 11th in total cases to date, the important number is that we are 32nd in caseload per 100,000 persons. That's pretty good comparatively still, even though cases are rising here and everywhere. And considering that we're about 10th in population compared to other states, you can see that our caseload numbers are much better over time than other states, and our death rate is about average. The next few slides we took from a recent publication by CMS. This data is derived specifically from Medicare claims. So it's all Medicare beneficiaries. And because it's from claims, we have to note that it's not complete in and of itself. There's always a lag time since all claims have not been submitted. And Medicare Advantage plans do not submit claims. So this is really only a partial look at the data. At any rate, you can see that the COVID caseload continues to affect dual eligibles, Blacks and Hispanics, and persons over 85 the most. And another thing is that we also know that if a dialysis patient if they get infected with the COVID virus, they tend to be very ill if they've contracted it. But it's unclear, though, whether there are more ESRD patients that contract the illness because they're more vulnerable or because they tend to interact with the healthcare systems frequently. But it has been pretty standard that the ESRD numbers are higher than almost any other group. In this next graph, you can see that persons having dual coverage, meaning both Medicare and Medicaid, tend to be more prone to getting COVID across all of the categories. Those are the yellow portions on the graph in front of you. This next chart shows us that Michigan still does have a fairly high rate of hospitalizations compared to other states for COVID, at least for Medicare beneficiaries. We are one of only 11 states with the higher rates of hospitalization per 100,000 persons. And here, excuse me, and here we can see that most often Medicare beneficiaries do return home after a COVID-related hospitalization. Skilled nursing facilities are receiving about 22% of these hospital discharges, and unfortunately 21% had died while in the hospital. About half of Medicare beneficiaries spend 1 to 7 days in the hospital, but a large proportion of patients spend between 8 and 15 days there as well. So those were some just brief updates about what's going on with Medicare and COVID. We're going to move on now to resources and guidance. We have a few updates from CMS. CMS for about the last 2 weeks have issued what they've labeled an urgent call to action to nursing homes. They have noted that the number of facilities who have at least 50% of staff completing the CMS targeted nursing home training is rather small. Only really about 12% of all nursing homes. So the narrative on this slide is directly from their press release, and they're strongly encouraging facilities to take advantage of what they're calling a no-cost opportunity. facilities, we've talked about this for a while, are probably all aware that they're in the process of making phone contact. We had not heard of any specifically being made in Michigan yet, but they're in the process of making phone contacts to facilities who have at least one active COVID case. They're going to do, this brief survey of a few questions. And in those questions, they're planning to ask about this training during those calls. The thing about this is that staff in general have been trained numerous times already, and we're in the middle of a major surge. And so there's been some pushback, understandably, from some providers who believe it's better for everyone to be working and serving the residents with support and monitoring than perhaps sitting in front of a computer program. So there are all sorts of training options, and we know a lot of providers have already completed a lot of training. So at this point, at least, it is still optional, but CMS does encourage it strongly, and they're going to be asking more and more about it. In addition, they've also issued a nursing home series for frontline staff that is accessible via podcast. This came out this week. It's designed, according to them, to reinforce infection control practices. And if anybody wants to look at it, at least the first in the series, the link is here at the bottom of the slide. And here we have a reminder that CMS is retiring the Nursing Home Compare website. The links to the new Care Compare website are on the slide. It looks much different if you've taken a look at it at all yet. They've moved a lot of information off the landing page, but you can still access provider data through the link on this slide. And particularly, in the past, you could get to the county positivity rates from the Nursing Home Compare website. And other than linking to it directly now, I'm not sure of any other way to get to it. So we've included that link for you here as you work to monitor the county positivity rates in order to determine your testing frequency for your facility. The old website will go down on December 1st. CMS, who obviously was busy this week, also issued a statement about holiday visitation. And this really doesn't include any new guidance. The visitation rules are the same as they currently were. They're all still in place. But we also know that here in Michigan, every county is now at a level E. So there's going to be very little indoor visitation going on anyway. Residents are obviously still allowed to leave the building, and that can be a major concern when community transmission is so high here in Michigan and elsewhere. So CMS is encouraging facilities to remind seniors of the risk of going out, and if they should decide to go out, what precautions they need to take. So those materials and the link for the press release are included here at the bottom of the slide. So before we move on to COVID relief facilities and CRCs, let's pause for some questions, if there are any.
All right, thank you very much, Deanna. Before we get into any questions, each year Leading Age Michigan honors individuals and groups who embody excellence in leadership, care, and service innovation, and who have made outstanding contributions to their communities in the field of long-term care. It is always a time of celebration and laughter. Join us on Wednesday, December 9th for a free live streaming event at the Leading Age Michigan Facebook page starting at 1 p.m. and lasting until 4 p.m. This year, we will be virtually acknowledging our many award winners, and we will be joined by two of Michigan's greatest resources, Monica Levin and Tim Cusack. We are excited to be able to acknowledge our many award winners and celebrate one another as we will do our best during these very challenging times. Leading Age Michigan would also like to thank our many dedicated business partners who continue to support our members, their staff, and the association in everything we do. You can see these sponsors up on the screen right now. So we would like to thank Omnicare and Matt Garlick over at Omnicare. We would also like to thank Andy McLeod and GMB. Therapy Management, along with Kim Murphy and Carrie Hensel from Therapy Management. We'd like to thank Sheila Ralston at Creative Dining and, of course, Tom Myers at Ziegler. Together with our sponsors, we know by working together and offering support to one another, we can overcome anything, and so we will please celebrate one another with us. We do have a few questions, so let me pull those up really quick. All right. We received and are using the provided antigen test for our assisted living staff and residents. We also require new independent living residents to quarantine or provide a negative test prior to moving in. Could we use the test provided to us for new IL residents? Just want to be sure we are using them appropriately. Thank you.
I haven't seen any guidance that says either you can or you cannot. I do believe that overall the department would think that testing might be good in that setting, but we will frame that as a question to them to make sure that the supplies are considered to be used appropriately if you use them in an IL setting. There is some discussion about at the state, the overall cost of some of these tests. But I do think that overall, we've always kind of had a sense that the department wants to make sure that everyone who should be tested gets tested. So we'll offer that question to the state.
Now that many HFA are now getting their waivers to use the POC tests, can we discuss use of serial POC testing? We may not have paid close enough attention to this when it was only an issue for SNF.
Okay, so I'm going to assume that you're talking about how often, or what the department would call the cadence for testing, as opposed to actually how to conduct the test. I'm not an expert in how to conduct the test, although I know that there are a lot of guidance out there. So if you're talking about the scheduling.
They said that, the cadence.
Yeah, okay, good. Well, the requirements are the same for nurse HFAs and AFCs pretty much as for nursing homes. There's some additional testing requirements for AFC residents who are going out for Thanksgiving. I don't have those off the top of my head. But at the very least, you need to test all new admissions on admission. A lot of our members have gotten that a bit confused. You don't have 72 hours after admission to do it. You have to test people on admission. You can accept a test that has been done up to 72 hours prior to admission. Obviously, if any staff or residents have symptoms, you need to test. If you have an outbreak, in other words, if one facility-acquired person, COVID positive, occurs, or any staff member, whether they got the virus in your facility or not, that will cause an outbreak, which means that all of the residents and staff must be tested immediately, and then at least weekly thereafter. The CDC suggests that you do it at least every 3 days for about 2 weeks if you have an outbreak, so that you can really get a good sense immediately of how deep that outbreak might be. For areas that are listed as A through E on the MySafe Start map link, you have to test weekly. So there's only one category in that system where you don't have to test weekly. And that's really about it. And we can certainly send out that protocol again if needed.
Okay, so it looks like there was 2 follow-ups to that, so I'm just going to read both. So we can solely use the POC test for asymptomatic staff when there is no outbreak. And then they also said, can we use just POC tests in the case of an outbreak, or do we need to upgrade to PCR?
I think that the intention for the state, and this is supported by the FDA and the CDC, that you can use point-of-care tests for all of those scenarios. You can use them for asymptomatic persons, and you can use them for an outbreak. In fact, you there's no way that you will get results faster using a PCR test unless you have one of those rare point of care PCR tests than if you use an antigen test. So if you have an outbreak, it's a good idea to screen everyone. If someone has symptoms or you're in the middle of an outbreak and someone tests positive, you should just go ahead and assume that they're positive. And the negatives, that's where you're most likely to get an error, is a false negative. But if you're going to test people in a serial fashion, the expectation is that you will likely find all of your positives eventually. The other piece is that there is a CDC algorithm to determine when to do PCR confirmatory testing. And basically, the idea is if you get a test result that you're not expecting, if you get a positive when there's low community transmission and no one else in your facility has it, that's a little odd. You have to treat them as positive, but you could do a confirmatory PCR test. If you have a person who's symptomatic or in a high area of transmission and the test says they're negative, that's something you really wouldn't have expected. So again, that's the place for a PCR test. But the point of care tests are appropriate for both outbreaks and staff screening on an ongoing basis.
Okay. Last week it was mentioned there is HUD guidance on testing of visitors in IL. I can only find in HUD FAQ testing as it relates to residents. Can you provide a link to the visitor information?
Okay, I think that was misspoken or miscommunicated. I don't know of any testing in IL. I think if I said that, I didn't mean that. I really think I was thinking about assisted living. So I apologize for that. I do believe that you can offer tests in independent living to visitors, but there is no requirement that you can't require it, and there's no requirement that you do it.
Okay. Are end-of-life visits allowed for non-COVID residents with current COVID cases in the building?
Yes, they are allowed for current, if there are current COVID cases in the building, but they're not allowed, unfortunately, if the person you're visiting has COVID. We have talked to the state about that a couple times, but there is no exception for a visitor to a COVID positive case at all, or anyone who's potentially exposed either.
Okay, it looks like that was the last question, so we can go ahead and move on.
Okay. So now let's get into the care and recovery centers and the COVID relief facility topics. We just want to remind everyone at the beginning of this discussion that much of the rules for these two provider entities come from Senate Bill 1094, and they are written into law. So, looking at care and recovery centers and how they are a bit different from COVID relief facilities. The MSA policy bulletins for each are noted on the slide if you want to look at them later. Obviously, in both programs, care is provided to COVID positive persons. The primary goal, though, of care and recovery centers is to ensure that there is a safe and appropriate place to move persons out of the hospital when they are in need of post-acute care. So even though there's safety factors about where they should go and having the appropriate environment, the primary reason for a care and recovery center is to keep those hospitals beds available in case there's a major surge, and also to make sure that there's a good and safe place to move some of these residents. A secondary purpose is to ensure that there is a place for residents who are in other nursing homes that might not be capable for one reason or another to serve COVID residents. COVID relief facilities, though, are designed to allow certain nursing homes to either retain their current COVID positive residents and allow them also to receive their own previous residents as they're discharged from the hospital. Obviously, there could not be enough care and recovery centers across the state to serve the entire COVID positive SNF population. And they have identified 2 levels of care for a COVID relief facility. You can either retain your current residents, or with some additional standards to be met, you can allow, they will allow you to admit new COVID positive residents, but again, only under certain conditions. The department does understand that in many cases it's much better to keep residents where they are when the facility has the capability to serve them. So we do want to note here that late last evening, the department did respond to our question about residents who are on campuses with multiple levels of services and residential types. So they did say that campus residents can be served as part of a retaining process and would not be considered a new admission. In terms of the minimum criteria that must be met, you can see that in order to be designated as a CRC, a care and recovery center, you must either have a 3-star rating in staffing or a 3-star overall CMS rating. That second part, the overall rating, was just recently added to the criteria. You can't be under a denial payment for new admissions, and you cannot be labeled as a red hand facility. None of those are criteria for a facility who wants to only retain its current COVID residents or accept them back from the hospital. Although there are some other standards that they have to meet in terms of their physical plant and staffing, etc. But there are no minimum criteria if you simply want to retain and readmit. But if you want to admit new residents, facilities must have a rating of 2 or higher in staffing, not be designated as a red hand facility, and you also must have some experience in serving COVID positive residents. We do know that there's a lot of questions about some of these criteria, such as the red hand icon. But we will discuss the department's response to some of those questions at the end of this section. Physical plant standards. First, you can note on the right-hand part of the slide that the plant standards are the same for COVID relief facilities who want to retain and those who want to admit. There's no difference between those 2 categories. There are, however, a few small differences between the physical requirements for a care and recovery center and the COVID relief center. A care and recovery center must have at least a separate unit or a separate wing, or obviously they can occupy an entire floor or an entire building. COVID relief facilities can use a set of rooms or a portion of a unit if needed, but you have to show the department how you're going to adhere to good infection control and containment standards if you don't have the layout, perhaps that a CRC is required to have. Both entities must have a dedicated area for donning and doffing and a place for new and used PPE. But for the care and recovery, but for the COVID relief facility, it's only preferred to have a dedicated staff entry, dedicated staff break rooms, separate restrooms for staff within that area. But if you can't include those areas in your actual unit, you do have to demonstrate to the department how you're going to contain and apply all of the infection control requirements to that area. And you have to put that on your floor plan as you submit it. That was one of the issues that came up with the first applications that they received. And obviously there could be no through pathways for residents or shared bathrooms with non-COVID persons. And that's true for both entities. Even though it's only listed here for COVID relief facilities, it's obviously true for care and recovery centers as well. For both kinds of entities, you must have dedicated staff and that's one of the hardest parts of this whole thing. And the staffing plan for direct care staff must be appropriate in proportion to whatever the number of beds you have in the unit or the resident census. In both situations, you must also have a qualified infection preventionist who has been certified using the CDC IP program. And obviously, you have to serve the entire needs of the residents while in the unit, which means that if they need rehab or if they have other medical conditions, you are required to serve the entire need of the resident. It's only stated for the COVID relief facility for some reason, but I'm sure that it's true for care and recovery centers as well. In terms of infection control, all staff in both entities have to be trained in infection control procedures. And as we stated on Wednesday, the CDC would also add that you should limit the entry of all of these types of employees to the point that you can. So you should be cross-training and allowing some of your staff to cover other activities than perhaps they normally would in other units, because you want to minimize the number of people going in and out of this unit. Both types of entities must have a policy and a process to monitor staff's adherence to infection control, and of course, an adequate supply of PPE. And in addition to having, and I'll be honest with you, this one did not make much sense to me. In addition to having an infection preventionist who's certified through the CDC training, a care and recovery center must also have a champion who's undergone some CMS training. That seems like duplicating the other role. I can't imagine that someone would have two different people in that role, but that's what the guidance says. Testing. Not a lot here about testing. The care and recovery centers, in order to apply, have to produce a recent history of their testing, actually all the way back to January, I think. No, 3 months, I'm sorry, a 3-month history. Both types of programs must have a plan to comply with testing requirements, and both are going to have to submit resident and staff screening procedures to demonstrate their ability to maintain infection control standards. Both types of facilities must have a communication plan that addresses how updates are going to be communicated to all parties. A COVID relief facility who is admitting new residents must also demonstrate ongoing communication with referring hospitals. And that's really all about bed availability and any supports needed to admit residents. And again, that's obviously to ensure that hospitals have a clear avenue to discharge COVID residents when needed and to help keep their beds open. A few miscellaneous rules and standards. There are additional data needed that MDHHS will review if you're applying to be a care and recovery center. You have to, they'll look at recent death to case ratios, your outbreak history, your survey history, and they will do a desk review followed by an on-site review. Facilities who do not apply or are denied as a COVID relief facility must transfer any COVID positive residents as soon as practicable, starting after December 1. If you have applied, though, but have not yet received approval, you can retain your COVID positive residents and take your readmissions, but you cannot admit new people. For both programs, the state reserves the right to change the standards at any time. And I would plan on them doing that if indeed the caseloads start going up and hospitals start feeling significant effects from a surge. The admission criteria. The admission criteria for both entities are a little complex. For care and recovery centers, obviously it's just persons who have not met the criteria to discontinue transmission-based precautions. But there's also language in there that encourages the hospital to keep the resident if there's 72 hours or less left in their isolation phase. But one of the things that was a little different here is in order to take a resident from the hospital, a care and recovery center doesn't have to ensure the patient meets the nursing home level of care, and that's written specifically like that in the guidance. And I'm not sure how they're going to do that, because it makes sense if you simply want to keep the hospital beds open, but we're unsure about what the payer source would be for some of these residents. If they cannot meet either Medicare or Medicaid payment criteria, if they don't meet the nursing home level of care. So we have a question into MDHHS about that right now. Care and recovery centers can also take admissions from other nursing homes, but those do have to meet the appropriate level of care, either SNF or basic nursing care level of care under Medicaid requirements. They will consider admissions from other residential settings, meaning assisted living, HFAs, AFCs, under an exception process, but only if the resident meets a nursing home level of care. For the COVID relief centers, however, it's much different and a little complicated. It's easy for retaining COVID relief facilities in order to admit their own residents back or retain their own residents. There's really no criteria for that. But in order to take new residents that they've not served, at least recently, back from the hospital, the nearest CRC must be 25 miles or more away, or the CRC must be full to capacity. Facilities can admit residents with special needs if a local CRC cannot meet those needs. You can admit any resident who prefers your facility to the CRC. But if you do accept any new admission, you have to document how it is that they were appropriate for your facility and met the exception criteria. And the department apparently has made kind of a big deal about that. So you should keep your documentation up to date. Discharges, there is a section in there that states when a care and recovery center can discharge someone, and it's simply anybody who meets the criteria to discontinue transmission-based precautions. The CRF, the COVID relief facility guidelines, silent on that issue, but we all know that all facilities must ensure a safe and appropriate discharge, whether the resident was COVID positive or not. For care and recovery centers, the state reserves the right to discontinue the program at any time, but it's important to remember that those care and recovery centers are going to receive a monthly payment just to keep their beds open. So they cannot take their unit down without a discussion with MDHHS and a transition plan. COVID relief facilities don't have to keep their unit going if they don't have any COVID positive residents. But if they plan to do that, they also need to include in their application, and I don't know how you're going to know this in advance, but this is what the state said during a meeting yesterday. They also need to include in their plan and documentation how they would safely transition the unit back and forth. So if there is some expectation that you think you're going to be taking that unit up and down, you need to think about that in advance. So here's the current list of CRCs and regional hubs. We also know that I think there are 3 more that just got approved yesterday. But in case you are looking for the contact information in order, if you ever need to move anybody or you're looking for a placement, if you're at capacity or whatever, these are the approved ones. We did hear yesterday that there are quite a few Also in the application process. However, the state still feels that there are not enough care and recovery centers all around. And remember that the hubs are actually in transition. I believe the Regency at Shane, which is has been a hub, has been moved up as an approved care and recovery center, but it has not been published that way yet. Okay, so we're going to review some of the questions that have come up and the answers that we understand them to be at this point at least, before we take questions from the members. So there were a few members who had concerns, and a lot of providers overall, not just our members, that they didn't fully meet the criteria for one or what they considered small reasons, one or more small reasons, such as an old red hand designation, or if they are just getting out of a current denial of payment situation. So yesterday during our provider call, the department did suggest that if you want to admit residents and you don't 100% meet the criteria, that you should go ahead and apply. You may not get it approved. They can't say whether they will approve, but your circumstances could, one, change, and they want to know that you're willing and looking toward taking these patients, because if the surge increases, they may have to change some of the rules for some of this stuff. Especially the red hand designation. That's, I think, in a later bullet, down at the end of the slide. There were several questions about some of these red hand designations that were really low-level citations, and they thought that maybe that would be something that the department could overlook. And the department said they would consider that. They didn't really guarantee that would be something that they would do, but they would consider doing it. So if you have a red hand designation, I would, and you want to apply, you might want to go ahead and apply. And if you have any extenuating circumstances, you might want to note that. When you submit your floor plan, you need to clearly identify where the COVID unit is on your floor plan. In their original guidance, they only asked for a floor plan, and so that's what they got. But they want to see the COVID unit on the plan, and they want to see on that plan how you're going to comply with the other physical plant layouts. So they want to see how that unit will be developed. Additionally, they're going to reach out to you if they don't understand that, if they don't understand the layout and how you're going to maintain infection control standards, and they will ask you for more information. They're also going to reach out to you if the data in your application doesn't match what they have otherwise, if your CMS ratings don't match, or if your survey history isn't the same as they think it is. So they will reach out to you, and they've been doing a lot of that apparently over the last couple of days. So if you do want to perhaps be able to take COVID patients in the future, whether you meet the criteria or not right now, they do suggest that you apply now rather than later. Even if you don't want to take COVID patients now, but you anticipate that you're going to have to, or you want to in the future, they think that you should apply now rather than later. And they are talking about extending the application period, but they haven't said anything that was decisive about that. One of the big issues that has come up is whether or not a resident can refuse to be transferred, and all of that is still up in the air. It seemed to us, when we reviewed the 1135 waiver, that transfers for appropriate COVID care were appropriate in terms of not applying the normal rules about resident rights and communication and voluntary discharges, all that stuff, involuntary discharges. So we thought that the 1135 waivers allowed these transfers whether or not the resident agreed. But we also heard from Laura, not directly, that they expect the resident to be able to refuse a transfer. So we've had several questions go to MDHHS about this, and they are still considering that. So that point is still up in the air. Another point that is up in the air is they have been approving plans for physical layout units that have temporary walls. But we did hear that some facilities have run into local fire department concerns about these temporary walls, et cetera. And the department said they're going to look further into that. To meet their needs, the temporary walls work. We're not sure whether or not they're going to work considering other regulations. The department is also about to issue guidance that allows care and recovery centers to ignore the 85% rule when it comes to cost reporting in terms of occupancy, the 85% occupancy rule. And although it is only allowed for the unit itself, and it's not going to be allowed for the whole building. So if someone's occupancy drops below 85%, simply because the COVID unit is being held open, they will look at that. But that 85% rule still applies to the rest of your entire building. And they are thinking about whether or not to extend that exemption for occupancy to the COVID relief facilities as well, but they have not made a determination about that. And again, as I said before, they will consider looking at the red hen designation. But at this point, it is just a consideration. And lastly, we do know that they are looking at allowing more hospitals the use of emergency swing beds for COVID residents in particular. So hospitals could technically put together a CRC if they wanted to use emergency use swing beds, and the state is working on finalizing that now. So before we take more questions, there's a couple things that keep coming up. Closed doors. Several of our members have gotten citations for not having closed doors in units that where there's an outbreak, or the whole facility, if the whole facility is under an outbreak status. And this is a major issue. I think that in some respects, it's considered a high-level citation, depending on, I guess, the situation itself. But there's some concern also about simply closing every resident's door all the time because you cannot see them. They're mostly confined to their rooms, and we all know that many of these residents have dementia, they have fall issues, and a lot of the facilities have some concerns about closing all of the doors for all of these residents if there's an outbreak in the facility. So that's something that we're going to work with Laura about, but right now we wanted to make sure that members were aware that we have heard that there are some citations out there for closed doors. Another question that keeps coming up is as more and more counties become red, nursing homes have to start doing twice weekly testing. And there are no requirements in the CMS QSO 38-NH that defines twice weekly testing. So what is the minimum amount of time that can be considered between the tests to make that work? It's not stated anywhere in there. We have sent off a question to Laura about that, and we're trying to work through some of the parameters around some of the discussion about that because they seem to think that this is an MDHHS requirement, and it is not. It is a CMS requirement. So we had to reconfirm that this is not a state rule. This is a federal rule. And hopefully they're going to get back and finalize their decision about that soon. Okay, so Blake, let's take some questions.
All right, we'll just hop right into those. So if you have a COVID positive resident passing while on hospice, their family cannot visit to say goodbye, even with full PPE?
That's my understanding, and I have asked that question to many entities. I think both CMS, because I cannot find any statement in the CMS guidance that allows any visitation at all to someone who's COVID positive. And it definitely is not in any of the state guidance either. And I consider this a problem, and I'm fearful that someone might be cited for that. But every guidance piece that I've seen does not allow visitation to someone who is COVID positive.
Regarding something said earlier, can a COVID positive resident who is at end of, oh, okay, so it's same question. We're getting negative tests within 72 hours of admission, but have had 3 new admits from a specific hospital eventually test positive a few days after admission. Our local hub is full and the hospital won't take them back because they are asymptomatic. We don't have a specific dedicated unit, just our observation unit with a dedicated CNA. Is this enough, and what other options are there?
I think that you're going to have to move them to some place together outside of your observation unit, because although obviously these persons, if they were admitted from the hospital, they are in your observation unit. You really can't keep them there because they're too close to the other residents, and so you really don't have dedicated staff taking care of them. In fact, you're moving a dedicated person from a positive, unless you don't have any other observation residents, then you're good. But if you have other persons in that observation area, I would think that your best protocol would be to try and group these people together if you can. If you cannot, keep them in their private room, keep the staff dedicated to the point you can. But you need to contact your local health department and coalition and make sure that they know that you have COVID positive people that you can't serve in a dedicated unit. Let the department know and document all of that. And then if you can't find a hub or a care and recovery center, we anticipate actually that that's going to happen more and more as the nursing home COVID rates go up. We don't believe that there's going to be easy answers for a lot of these people, and that to some degree facilities are going to have to try to comply with the infection control requirements as best they can and continue to try and move people to an appropriate place. But it's essential that you let both your local healthcare coalitions and the department know that you're in that dilemma, or you could perhaps get cited later for not maintaining the right kind of unit and the infection control requirements that they feel are needed. And I know that that's not the best answer, but that's the only unfortunate one that I have.
Do the donning and doffing areas have to be completely separate? Do they need to be just outside the unit or just inside the unit?
I'm not 100% sure what the surveyors would say about that. I had always thought that they needed to be inside the unit. The donning, I don't think has to be, but the doffing, I think, has to be. I would worry about bringing contaminated PPE outside that unit. But we can look to see if there's some specific guidance about that. I'm not an infection control expert and haven't had to think about that sort of thing in a long time. But I would be concerned about the taking off of PPE outside of that unit. And you're supposed to have separate areas for those pieces. In other words, you're supposed to have a separate area for putting things on, and I believe a separate area for taking them off, if I understand the guidance correctly.
Can you please clarify that proposed swing bed policy designations will only be temporary and during the federal state of emergency designation? LMI will continue to work with MDHHS on this topic.
That's correct. It's our understanding that the only reason why hospitals would be allowed to do this at all, except in rural areas, is because there is an emergency swing bed exception within the 1135 waivers. And this would be a temporary thing only as needed to deal with the surge. And yeah, we are in conversations with the department on a continuing basis about this.
Regarding the twice-weekly testing, is there any consideration for how much or little an employee works in the community? What if the employee only works every other weekend or 2 days per week?
There is, I think, in either the FAQs and the CDC guides, I actually think it's in both, that speaks to staff members who have been out of the facility for a significant period of time. And even though there is a twice weekly or a once weekly testing requirement out there, depending on where you are, I think that if they've been out for 4 or 5 days in a row, to make them come in just to be tested doesn't feel appropriate. But there is also in the FAQs a scenario where if they have been gone for a period of time and they come back, you must test them when they come back and allow them to work as long as you've screened them well for no symptoms and no exposures and resume testing at that time. I think that could very well apply here. I've not heard any decisions or discussion from the department either way, but I think that makes sense. There's no sense in them having them be tested more often than they're ever in your facility.
If new admit in TBP becomes positive in that 14 days, are they considered an admitted COVID or do we have to count them as our own?
If someone is admitted into your facility and becomes COVID positive within that 14-day incubation period, they are considered not facility acquired. That is externally acquired, and you do not have to count that as an outbreak.
Does the testing for residents leaving for Thanksgiving or for an overnight apply to AFC only, or does it apply to HFA and SNF also?
My understanding is that for some reason that I don't understand, it only applies to AFCs.
Okay. I think I just heard you say that we are not allowed to allow visitors for end of life of a COVID positive resident. I had thought that changed and we could allow end of life visits.
I can't find guidance to that effect, and although I've asked several times, the department hasn't really ever responded to this issue. Both the visitation guidance, which I think was first or last, let's say last issued on October 21st, clearly says that visits are never allowed for anyone who is COVID positive. I've asked at least twice that I remember. You have to remember we talked to the department about a lot of things and we put out a lot of questions to them. But I've never gotten a good response because I would think that at least end of life visits would be something that could be allowed. But I can't find guidance that says that's true. In fact, there's guidance that says it's not true. And that's part of the dilemma.
All right, thank you, Deanna. It looks like that was the last question. So if anybody thinks of anything after this webinar has concluded, as always, you can shoot an email off to Dalton, Deanna, or Safe and Calm at leadingagemi.org, and we will make sure to get that question answered for you. So at this time, we would like to thank both Deanna and Dalton, and we would also like to thank the 90 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Just a reminder, we will be holding our Safe and Calm webinar next Wednesday at 10 a.m. Eastern Standard Time as always, but we will not be holding our webinar next Friday. So again, we will be holding it next Wednesday. Other than that, I think that takes care of everything. So I hope everyone has a great Friday and enjoys their weekend. We will see you guys all soon. Thank you.
Be safe, everyone.
Have a good weekend.